And so when we start thinking about cases, it's a helpful table to just start thinking that if I'm faced with this, so when you're talking with your clients, start thinking if they're faced with this, what would that be? And there can be triggers that are internal and they're external. So external triggers are anything outside us that are in the environment. If I touch this, if I read this article, if I, again, throw a piece of trash away, if I have to go to the doctor, or they can be internal. So suddenly the number 9 pops up in my mind, or I have a thought that suddenly that I'm really dirty, or I have a bad thought. So a thought about sex comes up in my mind, and I deem that as a bad thought. So triggers can be internal or external. And then I fear this image or I fear this thought coming up in my mind. And so obsessions are, as I said, the intrusive piece that comes into our mind. It can either be an image or a thought. I must do this in order to be okay, and that's compulsions. The compulsions are any part we're doing to try to solve the obsessions. What I love about OCD is that it's really not that smart. And I don't mean the people, I mean the OCD itself, because the OCD it lands on a handful of core obsessions usually. And so it's, and we will talk about some of those core obsessions, but when you can identify what those core obsessions are, it will help drive your treatment, because there are many triggers that can bring up the obsession, but the obsession stays very static, stays very much the same oftentimes. And clients might have a obsession in a couple of different areas, but it doesn't tend to jump from one item to the next item to the next item. The triggers jump, but the obsessions tend to not. The compulsions can be things, so again, we're going back to compulsions are anything we're trying to do to solve that obsession or to feel better about the anxiety that that obsession creates. And so compulsions can be things like behaviors. That's what we usually think of, hand washing, right? Or we checking our lock, going back and forth, repeating something. Compulsions can also be thoughts, can be cognitions. And so our compulsions can be trying to review, trying to remember something, or arguing with the obsession. We think, I touched the doorknob, maybe I have germs, and the compulsion could be, no I don't, I know I don't have germs, I know my hands are clean. It's going over and over, we're trying to answer it. Other cognitions can be trying to put a good thought in, when you have a bad thought, you're trying to balance it with a good thought. So I've had clients that have had a fear of ALS, and so the bad thought is every time Stephen Hawking comes in their mind, and then they have to counter it with another name of somebody they know isn't sick. And avoidance. And so that looks like if I'm fearful of getting germs from the doorknob, I'm not going to touch the doorknob. It's the I'm not going to go to the doctor because the doctor causes me to, because I'm avoiding the anxiety that's going to come. Really interesting, the compulsion avoidance and the triggers often go hand in hand. So if I have to go to the doctor, I'm going to get anxiety, and so my compulsion is to avoid the doctor. So the triggers and the avoidance can be very similar. Compulsions also can be dysfunctional or non-functional. And so dysfunctional means that they're behaviors that we typically need to do, but we're doing them in excess. So we like to wash our hands after using the toilet, but if we're doing it for 30 minutes, that's in excess. So we have to work to set what is realistic. When we're talking about a dysfunctional compulsion, we're working to set it what's realistic. What is a right or a appropriate amount of hand washing versus an excessive amount, and dysfunctional versus non-functional. Non-functional is when it's not a behavior that's necessary, and so it's things like avoiding a color. Avoiding the color green because it causes the obsession, avoiding numbers, going through the trash because you have a fear you've lost something. And the pattern of OCD, we're just going to review this one more time, but it kind of, I want to show that we have the trigger, And that's, if I'm faced with this, then I'm going to have this obsessive thought, my anxiety goes up, and I do a compulsion to try to bring my anxiety down. And the problem with it is it does work, right? It does bring it. If I feel like my hands are dirty and I go wash, I'm going to feel clean. But with OCD, the feeling good or the anxiety coming down only lasts a brief time. And then it loops back around, and our brain starts making a second guess. It's called the doubting disorder. Starts making you guess again of going, but did I really get clean? Maybe I didn't use enough soap. And so that's the trigger again. The obsession starts popping in. I really do have germs. And so this time I'm going to wash, but I'm going to use 2 pumps of soap. Okay, I think I'm clean. My anxiety goes down briefly, and the next time I go to touch the doorknob, my anxiety goes way up, and I think, oh no, I have germs, and I think, oh my gosh, I'm not sure I really got clean last time, because why am I still thinking of this? And it just keeps looping around and never gets answered. So OCD is trying to gain certainty about something. OCD is trying to convince us to be 100% certain about something, but can we really be 100% certain about anything? No. It's also that it doesn't respond to logic. So if we're trying to argue with ourselves or we're getting reassurance, it really just makes us feel better, but briefly, and then cycles back again and reinforces the OCD. And I always tell clients, untreated OCD tends to grow, because what alleviated the anxiety previously, the OCD demands that that gets bigger, because it keeps making us doubt and second guess, so we do more and we do more and we do more, and more and more and more of our world gets taken over. So now that we understand the distinction and the differences of the components of OCD, let's jump back into the assessments. Because when we're doing an assessment of somebody, of a client, we really want to be starting to identify the triggers, the obsessions, and the compulsions. And so here's just some ideas of questions to ask that are helpful, of like what causes the client to feel anxious and to what degree. That would be our triggering points. What happens if they don't, if they face a trigger and they don't ritualize or they don't do a compulsion? That's going to help us identify what the obsession is. What's the ultimate consequence? That helps with figuring out what the obsession is. We want to know if what they avoid. That's back to the compulsions. And then how much do they believe the rituals are senseless or excessive? This is what Lauren was talking about, that if clients have limited insight, treatment is much more difficult, because you have to treat the limited insight before you can be able to properly treat OCD with the ERP, and we'll talk about the exposure response prevention in just a minute. To what degree are the symptoms interfering with their life? We want to figure that out. How much is their life being impacted by it? Are there other comorbid disorders that we need to be able to face first? And then how did the OCD start and develop and change? That's really helpful, because a lot of times clients might have overcome one area of OCD, and we can use that as increasing motivation to help them face it in the future. What previous treatment did they have, and did they have an adequate trial of exposure response prevention? Again, a lot of clients, we think of the 17-year mark from the time that they've had an onset of symptoms to the proper diagnosis and treatment. That's a long time, and so we're having to overcome a lot of things that they've learned from other therapists maybe that have tried to treat it with logic, or tried to treat it with thought challenging, and really that doesn't work for OCD, as we've already discussed. Motivation and expectations, we want to establish this so that we have a correct expectation, and we'll talk about that again in just a minute, as well as helping build motivation. And then the last thing is, are there any obstacles that need to be addressed, such as poor insight, or if they have family accommodations, if they have other behaviors that are interfering with treatment. I currently have a young man in my practice right now that has maybe delusional disorder, but because they're using a substance, it's hard to tell if it's an obsession about a fear that somebody's going to harm them, or if it really is a delusional disorder related to the substance. And so until we get rid of the substance use, treating them for OCD is really not going to be effective, or even proper diagnosing. There are types of OCD, or types of obsessions. And so this, again, helps us to do our assessment. And so there's contamination. That's if somebody has a fear of bodily fluids, germs, diseases like herpes or HIV, environmental contaminants, so maybe fearful that they would have come in contact with lead paint. I have a client that is terrified of coming in contact with anybody who smokes for fear that they'll have lung cancer, so that's an environmental contaminant. Household chemicals, so they might be fearful of cleaners. I've had clients when they put in new carpet, their anxiety went way up for fear of some of the different chemicals that would be in carpets, and dirt. Unwanted sexual thoughts. This is where someone would have obsessions about sex with an unwanted person or a perverse act of sex, maybe being violent in sex, having sexual thoughts about an inanimate object or about an inappropriate person, so a family member or about a child, thinking that a relative is attractive, losing control. That would be like what I was talking about, a fear of that you could commit suicide, a fear that you might act on an impulse and harm somebody else, or act on an impulse and harm yourself, a fear that you might harm your baby, that you might have had several clients that fear that they might lose their mind and accidentally harm women or children. Religious obsessions, it's also known as scrupulosity. And so they have a concern with offending God or committing blasphemy, committing the unpardonable sin, or a repetitive obsessive thought about their salvation. And a fear of harm, that you might run over someone or that you might be harmed, or the things that you're doing might cause other people harm, such as if you were to drop a piece of trash on the ground, that someone else might slip on that and you would be responsible for their harm. I'm working with a client right now that has a fear of that they have a fear on two sides. So they have a fear that they'll get contaminated, but then they also have a fear that maybe they are contaminated and everything they touch in the grocery store, if they don't buy it, then they run the risk that they might be contaminating someone else. And so, yeah. And I think, how many items do you touch in the grocery store? A whole lot, right? Yes.
Going back to your client who uses alcohol or drugs?
Marijuana.
Yes. Could that be the compulsion in order to try to get rid of the obsession?
Oftentimes, clients do self-medicate, and so they may do that attempt to get rid of the obsession, but not in this case. But yes, that is a very good.
And if it is utilized in order to alleviate the obsessive tendencies?
And I don't know if you have a specific question to that, but if that is, when I see somebody for that, I want to know, again, kind of their level of insight of if they know or see that that's what they're doing. And then I will really encourage them to start working with a psychiatrist so that we can at least regulate what kind of medicines they're getting to be able to help manage their anxiety. But I will go at it from that direction of going, you're self-medicating, let's do it in a way that's useful. Yeah, that's good questions. And other obsessions, the obsessions related to perfectionism, that's where things needing to be even, things needing to, a concern with needing to remember everything. It's a person that reads every word on a page because they're fearful that they'll miss something, or that they might forget some important information. Uh-huh.
What's the difference in scrupulosity versus obsessions versus religious delusions?
So, well, part of it would be our level of insight about somebody, so, or not our level of insight, but the client's level of insight. And so I don't think that a lot of times people with schizophrenia don't have the insight to see that that really is an inaccurate fear. The other would be what other criteria clients are meeting with schizophrenia. And so with OCD, they're not meeting some of that same, yeah, they aren't they aren't having hallucinations or some of the other odd behaviors that show up with schizophrenia. Yeah. And then last, just other obsessions that can show up are fear about illnesses or superstitions about lucky numbers, relationship OCD, so it picks on the person that they love, or they might obsess about did they make the right choice in who they chose to marry. And types of compulsions, so there's washing and hand cleaning, or excuse me, washing and cleaning. That can be washing your person or your, like hand washing. It also can be a laundry routine or a house cleaning routine. Checking behaviors, going through, checking that you didn't cause someone else harm, checking that you're keeping harm from happening, like checking your locks. I've had clients that record themselves. Talk about unnerving in your own session, right? They have a little recorder in the pocket and they come in and are recording it, but they're doing it because they're wanting to be able to go and review for themselves later. Did they lose their mind and harm somebody along the way? Checking that nothing terrible has happened and that they've not made a mistake. That's where somebody would review and go over their paperwork, or review over and over when they fill out a form. Repeating behaviors, that's also very similar to the checking, but repeating that's often that they have to do that action again until it feels right. So they might have to walk through a door several times, or they might have to, I have clients that get dressed and undressed multiple times in the morning just until they feel like that anxiety has come down. Repeating bodily movements, so that can look like tics, but it's often blinking or tapping or making a face or sighing out loud. Or I've had a couple clients do grunting, but again, it's a compulsion. Mental compulsions, these are tougher, and what I think a lot of us as practitioners have missed over the years, and we used to call them pure O's, people that had just pure obsessions. They've now discerned and decided that there probably are no pure O's, that people really are instead doing mental compulsions. They're doing something in their mind to try to bring the anxiety down. So when somebody's trying to solve an obsession, they're trying to think through it enough, or they're trying to go back and review history enough of going, did I really harm somebody? Now, is it possible? Now, why would I think that? When that would be a compulsion. So our compulsions are anything we're trying to do that answers that obsession, anything we're trying to do to bring our anxiety down. Ordering, that just makes sense, and reassurance seeking. So that would be when we're confessing to our family members, or we're getting reassurance from friends. We're calling people up and asking the same question over and over. People confessing to their priest until their priest is telling them, please don't come anymore. You don't need to tell me those things. Oddly enough, it happens all the time. Going to doctors. So your doctor is telling you, you need to not come anymore because there is nothing wrong with you, or seeking medical tests. And then avoidance. And so that, again, is easy enough to know, but that's the person that is avoiding doing something. They might avoid knives or avoid changing the baby's diapers and because of the fear. So once we have a good handle on our client's OCD, then we want to move in and end the assessment, then we want to dive into treatment. And so the very first thing I like to do with clients is have them make a motivation list or an outcome picture. I'm about to ask them to do really tough stuff. So I need to get them on board. What has OCD taken from you? Why would you want to face it? Because it's not easy facing OCD. The whole title of our presentation is Be a Fear Facer. We're gonna ask them to start stepping into the fear instead of stepping away from it. And so I really spend some time getting them to help come up with a motivation list. I wanna develop their outcome picture of what life would look like.